Okay, good morning, everyone, and thank you all very much for joining us on this Thursday morning for the next installation of the eArchiving webinar series. My name is Thomas Phillis, and I'm going to be moderating today's session. I see people are still connecting, but first we'll just cover some of the housekeeping rules of today's session, and then we can move on to the actual presentations. So I think everyone is quite familiar now with how we run online meetings, but I'll just go over the basics just so everyone's familiar. First of all, after you've connected your audio, we ask you to please stay muted throughout the session, and this is obviously to make sure we can hear everyone. There is a chat function for questions and comments, so just put your questions in there to the speakers and we will address them in the dedicated Q&A section. And please note that this webinar will be recorded and published, but none of your personal data will be published with this recording. Okay, so a quick look at today's agenda. So as said, I'm Thomas Phillis from the CEF Stakeholder Management Office, the Commission's Informatics Directorate, so I'm going to do a quick welcome. We've got Dr. Jamie Kaminski, who is going to give the eArchiving building block welcome and is the training lead for the eArchiving building block. We then have Karen Brandenberg from the Kommunalverbundet Zuidarchivaria, who's going to talk us through the eArchiving core specifications. We then have Honne Marie Kindlev from the Norwegian National Health Archive, who's going to talk about the Norwegian National Health Archive project. And finally, we'll have Stephen Mackey from Pickle, who's going to introduce the eHealth 1 content information type specification and software tools. And then we will have a combined Q&A for all of these presentations. So we've got plenty to get through. So yes, I'll just do a quick welcome. So the eArchiving building block is funded through the Connecting Europe facility, which is the EU's, well, formerly major financing instrument for trans-European interconnectivity. This year, the CEF program comes to an end, and we will move forward to the Digital Europe program, which is still currently being negotiated between the Council and the Parliament. So we haven't obviously got any positions to take, as the program itself is still under negotiation by the co-legislators. So just a quick word about how CEF is governed, although it doesn't concern us too much, as this is very much the outgoing model. CEF is governed by a regulation, which is then further underpinned by a number of guidelines and then several annual work programs. CEF funds a catalogue of building blocks. I'll quickly go through them. We hope that these building blocks will go forward into the Digital Europe program, but as I said, the exact nature of this program is still being discussed and debated. But we have the big data test infrastructure, which is a sandbox environment for experimenting with data sets open to public sector and public sector projects. So that could be a private project partnered with public sector. We have the context broker building block, which is an 8 standards-based API for harnessing real-time data to build smart services and smart solutions. eArchiving we're going to discuss in some detail today. The European Blockchain Services Infrastructure is a blockchain infrastructure at European level that's built on several specific use cases, such as diplomas or notarization or self-sovereign identity. The e-invoicing building block supports the introduction of the European standard on e-invoicing, supporting the digitalization of end-to-end electronic invoicing and procurement. The eID, e-delivery, and e-signature building blocks all help implement the eIDAS regulation. For those of you who may be aware of it, that's the regulation on authentication and trust services within the internal market. The eID building block supports member states with the interconnection of their national eID means. E-delivery secures payload and content agnostic secure cross-border data exchange. And the e-signature building block, as the name suggests, supports the creation of electronic signatures and timestamps and e-seals that are technically and legally interoperable between the different EU member states with different levels of security, all in line with the relevant European legislation. And e-translation is a machine translation tool that can be built into cross-border services to make the content obviously available in the EU 24 official languages, plus Icelandic, plus Norwegian, as well as a number of non-EU languages, including Turkish, Japanese, and Mandarin, with more to come. And it's also open to public officials and SMEs. How does CEF support projects using the building blocks? Each building block has pretty much its own specific service offering, but they do share some basic commonalities, and these include training sessions, so similar to what we're doing here today, sample software that is standards based. So obviously the goal here is to make sure that we build solutions and services based on common standards. Obviously to make sure that technological change doesn't impede the work that we're doing. But the Commission offers sample software which can be marketized by a private company or used directly, and testing services, so to test if the solutions built are compliant with the standards. How do you use a building block? As said, each building block has its own quite unique service offering, and obviously we can support you in how to use them, but effectively, again, at a high level, it can be conceptualized as you can build your solution from scratch based on the standards that are at the core of each of these building blocks. You can buy a compliant solution from the marketplace, or you can reuse the sample software that the Commission provides on the CEF website. But the key thing to understand is that all these building blocks are based on open and international standards to ensure a level of sustainability. Okay, now that I've set the scene, it's with great pleasure that I hand over to Dr. Jamie Kaminski, who's going to talk through the CEF eArchiving building block. Jamie.
Thank you. Can you hear me?
Yeah, loud and clear.
Fantastic. Well, thank you, Tom, for that really helpful introduction, as always. As Tom mentioned, I'm the head of training for the eArchiving building block. And as such, in this role, I'd like to extend my welcome to all of you to what is the 9th of our training webinars. Today, we're covering a topic that we've not featured before, so we've got quite a few new faces. So I'll say a few words about the background to the eArchiving building block, just to get everybody up to speed. So the building block, thank you. The building block was created in 2018, in late 2018, and its aim is to provide specifications, software, training, and knowledge to help people preserve and reuse information over the long term. Now, all of this information, all of this historical background, all of the information that I'm talking about today can be found on the eArchiving building block website, which you can see on the screen now. The URL is on the screen, and I'll also provide that in the chat box after I've finished. Next slide, please. So in terms of what does the building block do? What does it provide? Well, we provide a variety of eArchiving services. So, for example, we maintain technical specifications. In our case, the core specification is the common specification for information packages. We're lucky enough today to have one of the architects of CSIP speaking this morning, but more on that later. We also provide open source tools that you can download, use straight away. We have compliance and validation services that ensure that specifications are followed. We have a service desk. We have outreach and community engagement activities. And we are developing a training offering of which this webinar is a part. And the training will be delivered in the form of webinars like this, video-based training, and modules on the Moodle platform, amongst others. But this obviously is very much driven by the pandemic at the moment. So let me give you a brief preview of our forthcoming webinars. So the webinars run on the second and last Thursdays of the month. They start at 10 CET, 10 in the morning. And the next webinar will be about eArchiving of relational databases. And that will look at recent developments in relational database archiving using the eArch format. That'll be followed by a session on eArchiving conformance made simple. And that'll provide a technical understanding of the main open source libraries available through the eArchiving building block. That'll be followed by putting the SIX content in the CSIP package. We'll have Karin back again to give us an insight into METS, that's the metadata encoding and transmission standard, and how it's used to create a package that adheres to CSIP. And that'll be followed by a look at the different ways that standards are used to create a SIX. And that's a content information type specification. Then we'll have 2 sessions on the practical applications of digital archiving, focusing on validation software tools and submission agreements. Then we'll have a break over the summer, because I think we all deserve it, and resume with sessions about the eArchiving reference architecture, validation, and eArchiving geospatial data. So there's a lot to look forward to over the coming months. Next slide. So as Tom said, the webinars will be recorded and they'll be made available on the eArchiving webinar webpage, which you can see a screenshot of here. And on this page, you'll have access to the PDF of the slide deck, the recording of the webinar itself, and if you look on the far right-hand corner, or the column, you can see a link to the anonymized answers to questions that have been asked at the webinar. So there's a lot of material on this site. Next slide, please. You can also find our recordings directly on the CEF Digital YouTube channel, which is a superb resource in its own right. It has videos not only from eArchiving, but from all the building blocks that Tom talked about earlier. So it's well worth a look if you haven't done so already. Next slide. Thank you. So our webinars are part of a broader range of outreach activity. And that includes things like workshops and presentations at conferences, but obviously, as I said earlier, that's been somewhat curtailed by the pandemic. But as soon as those resume, so will we. But in terms of communications, we've got a LinkedIn group. You can see the details on the screen here, and I'll provide that link in the chat box later. We've also got a Twitter handle, so please do sign up to the social media if you haven't done so already. Now, today's webinar will explore the development and use of the specification for eArchiving patient medical records that's been developed by the eArchiving building block. And as Tom said, we'll have 3 speakers. Karin Bredenberg will introduce the underlying specifications for the eArchiving building block. Hannah Marie Hintcliffe will give us a case study of the use of the specification in the National Health Archive. Stephen Mackey will give us a detailed introduction to the actual eHealth specification itself. So our first speaker is Karin Bredenberg. Karin is the metadata strategist at Sudakavira in Sweden. She currently serves as the chair for Premise EC. She's the co-chair for TSEAS. She's the chair of the DILSIS board, as well as being a member of the METS board. And she is also the specifications activity lead for the eArchiving building block. And that's why she's here with us today. So, Karin, over to you.
Thank you, Jamie. I'm starting off with a winter image. I haven't seen snow in a while, but let's fly away to the next slide. So you have had some ground setting being done already, but I'm going to make it even more ground setting and actually set the stage for Hannah Marie and Stephen. So we have chaos. And it's a huge digital chaos. We have PDFs, we have images, we have scans, we have X-rays, and they are all just flowing around. And somehow we need to transfer this and make it a more civilized world. And you have already heard the acronyms. I'm going to mention a lot of acronyms today, and I'm living in acronym land. So we are going to look into the basis of CSIP and the SITs. So the stage is really set for Hannah Marie and Stephen when they take over from me. So if we go to the next slide, we have the chaos. And guess what? Everybody wants the information or the data. We have a civil servant doing something. We have the public doing something that ends up in a system. And what we want to do is move that around or transfer it. It needs to be published on the web. We want to transfer it to another institution. We want to transfer it to another hospital. We want to show it using it as open data. I know we are in the area today where we can't really show it as open data, but imagine we are using the same specifications regardless of the type of information we are transferring. The citizen wants to have access to the data. And guess what? We need to store this, most of the things, for a rather long time. So we want to put them in a box and put it into an archive. And guess what? People want things from the archive. What we do use when we do talk about archiving is the OAS reference model, Open Archival Information System Reference Model, an ISO standard. And you have the image down to the left. It's a rather dry thing to look at. And if you've never heard about it before, it's easier to go shopping. We are talking about 3 different bags, actually, or containers. We have the submission information package. I'm going shopping, I fill my bag, and I'm coming home. I want to put that into my storage. When I put it into the storage, I make it an archival information package. And I can have a lot of strategies. I also need to have some management. I need to take care of the things I have in my fridge. I know eggs, even if it says 1 month, if I'm keeping it in the correct temperature, they are lasting for 2 months. The milk, maybe not 2 months, and so on. And I also need to look into how do I split it up or something, or is just the bag I take in is the bag I'm storing? Or do I split it up depending on the type of information it has or the content, milk on the milk shelf, and so on? And for some reason, people think I'm good at cooking. They want to make a dissemination. Please go back. They want to make a dissemination into my fridge. So I have to make a dissemination information package. And here is where I can do either take the bag out as it is and create a meal. We're not going to talk about how the meal actually destructs my information, but the ending goal is the meal. Or I can pick the things my customers or guests want to have and create a dissemination information package. So that's where we are starting off. We are going shopping, taking care of the shopping, and giving a meal to someone who deserves it. Next slide. What we are doing in the eArchiving building block is working with specifications. We can't make this information move around if we don't have specifications. They are housed on these 3 different links. Most of the specifications are in GitHub. We also have the DLSS board webpage where we have textual information and where we also publish the reviews of these specifications, because everybody is invited to comment on these specifications and the other documents we are creating, because everybody needs access to all the experts about the different information types we are talking about. We need comments from the people developing things, so everybody are welcome to give us comments. When we look into them, and go to the next slide, the basis and the basics for all these specifications that we are working with, both the CS and the SITs, are standards. Next slide. the world of standards is colorful, and we do have a lot of standards. This image has been around for a long time, but it's really, really good at seeing, and as you see, visualization of the metadata universe. These are the standards that were available a couple of years ago. They are still around. They have been grouped here in the different sectors where they are used or with the purpose they have. And you have the small stars giving the standards and where it's used. This image can be filled with even more standards today. So this is really what we need to take into account when we start looking at transferring information and moving the information around. What or which standards should we use for what? If we go to the next slide. The common thing currently is that most of these standards are using XML as the format to describe them. We need to have something, we are talking archiving, information transfer. It needs to be around for a while. It needs to be around longer than tomorrow. We're talking about a very long time. So XML, which is readable both for the machine and the human eye, if you do it correctly, has been chosen for now. But of course, as the evolution goes on, we are looking into if XML is not the format to use, of course, we will be using other formats, but currently it's XML. And as I said, standards, if we go to the next slide, we have a number of standards that are being used currently. For the packages, you have already heard the mention of METS and the metadata encoding and transmission standard. That's what we are driving the information packages from. But we are using a lot of other standards. You see the current ones, and I can say that image, for every specification we do, we will get 1 or 2 more standards. So it's really using what's around, not inventing anything new, because the basics of creating the standards, that work has already been done. We just need to find out how we use them. So we use them in a common way. When we look into the next slide, we do have, as you already heard, 2 different types of specifications. We have the information package specifications going by CS and the content information type specifications, the CITs. On the next slide, I'm going to show you the CS specifications. That's described in the package. They are the top level specifications. And we have divided them into a number of specifications, because when you look at my shopping bag, it do get different stamps where depending on where I am in my shopping cycle. When it's coming in, it's a zip, and I do want to have some special information just in that occasion. But still, comparing it to when it's in my fridge, I still have some common information. So that is in the CSIP. That's everything that is common for all the information packages. And then they are the CSIP extended with the eArch SIP specification, the eArch AIP specification, and the eArch DIP specification. So it's already, we are creating a net of specifications that enhance each other. If we look into the next slide, so the bottom part, it's good to have the bag. See the CSIP and the SIP and AIP and DIP specification as being our bag. We need to put something into the bag. We need our grocery shopping list. And those are described in the content information type specifications. So and in the ideal world, we could use one specification for everything. I'm not going to make that specification. We are not making that specification because you can't describe everything in one common way. Therefore, we have the content information and type specifications, which we have split it up. So they are for just a specific information type. If we go to the next one, as you heard, we have been around for a while. The image on the slide before was the number of specifications we started off with. When this year is over, we have this number of content information type specifications. So these are the ones that really are extending. The information package is stable. We are refining the language in the descriptions of the different elements that are present, but what's really increasing is the content information type specification. And here is where all the sectors are important. We need specialists from the different sectors to actually provide us and help us. As you heard Jamie mentioned, a number of different specifications or groups I'm part of. We are handling a number of standards. There are other standards available which we need to actually tell people how to use, because that's often a problem with a standard. You have the standard, but you don't know how you should use it. So as you see, it's a lot of work going on. In the other webinars, there will be mentions of and a specific focus on some of the other specifications. Today, the focus is the eHealth 1 and patient journals specification. So trying to move on and doing some more ground setting. We need to move to the next slide. And a specification is kind of boring. It's just a text with rules. Nothing funny or exciting there. And when we look into the next slide, what we really do have is that we have a number of documents, or actually it's XML or meta markdown. So we have the specification, the blue book. In that book, we give the requirements. The requirements aren't any good if we don't have some sort of rules to be able to actually create the requirements, so we can create these XML documents. That's why we have an XML schema or schemas. Sometimes there is more than one schema used. But XML, you want to sometimes write really, really elaborated rules with conditions, depending on other conditions. And that's where we put the pink bunny into work using Schematron. That is what creates the specification. I'm kind of a boring person. I prefer to just have the specification and really reading the requirements, but I know not everybody is like that. So we also either to each specification, depending on the specification, or sometimes it's better to group them together. There are a guideline describing the standards that have been used, describing some of the tricky and sometimes how are these requirements connected descriptions. And we also have, well, in Swedish examples in English, an example showing the specification in use. So having an XML schema gives you the rules, but to show it in use, you have an example. So we have an XML document, and actually in the final end, a small information package, demonstration information package for just this specification. When we go into and look even more into the specification on the next slide, here is where I say it's boring. Nothing really exciting. It's just tables. It's a lot of tables, some minor text chunks, but the important part is the requirements, and those are expressed with the help of tables. And all of the specifications are built up on like this. Some have a lot of tables, others have a smaller part of tables, smaller tables, depending on the information we are transferring and how the standard we are using are looking. In the next slide, we see the two key terms. Reading these tables, we need to understand the occurrence and the obligation we have to use them. So cardinality answers how many times can we use this requirement? or actually we are describing elements and attributes in an XML schema. One-to-one says it's mandatory. Then you have a number of other ones. But we need to tell how to use them. We also have that we have put in a level. So using must, should, and may to really make it more, yes, you must use this. And sometimes when something is optional, you may use it or you should use it. So that's also things to see and understand in the specifications. That's the ground setting part. We can read the specifications, I hope. In the next slide and the following slides, we will delve in a little more into the information package. So the CS. Next slide. So the package has principle and requirements, and we are using the standard METs. So on the next slide, what we first can see when we look into the CSIP is a number of principles. What makes a package a package? How do we know that it really is a package? Some parts about we need some descriptions, we need some administrative information, we need to identify the package. I love getting presents, but most certainly I want to have an identification on it so I actually know what it is. We also need to have structure. So combined with the principles, on the next slide, we also are setting up a folder structure. What we see in the requirements can be seen as a manifest. We have a textual way of describing the information package. But what happens if we don't have that file? It gets lost. Someone steals it from me, or something happens and all for a sudden I can't read my XML documents with the name METS XML. What do I do? Well, that's when we have the folder structure. We have sorted the information package up in the main splittings following how we have described the principles. So we have metadata and the types of metadata, those folders. We have the representations, the data we are transferring and the different versions of it. We have the schemas, the ways of validating the XML files we are sending. Even if we, as I just said, we couldn't read them, but we do have them. And we also have documentation. And it's also possible to add other folders. Because when we move this, especially when we move it to an archive, there are extra documentation needed to understand the data. There might be the need of having a user manual for the system that the export and the transfer of information has been created in, to understand and really see, okay, this was how they used that system 20 years ago. Okay, then I understand why I have these tables or why I have these images. Okay, making it easier in the final end for the one making the dissemination. Moving on to the next slide. Using METs and the different packages and how they are relating. This is going to be the really quick crash course in METs. On the next slide. METs is a de facto standard for how you describe an information package. It has 7 sections where we are focusing on, not all of them, we are focusing on the top 5. The METs header gives information about the information package and who has created it and when was it created. We might have descriptive metadata giving information about who it's from and things like that. The administrative metadata section. What technical information do we have of the transfer we are making? Do we know something about that X-ray machine who has created these X-rays that we are transferring? Do we have the data from that one, being able to combine that with the X-rays. So we actually, in 20 years' time, when we need to do something with those X-rays to make sure we can look at them 40 years away, what information can we gather there to make it really, really possible to maintain forever? And then we have the files. They are placed, so the data files that we are transferring are in the file section. And in METS, there are one mandatory and required section, and that's the structural map. The structural map is seen following the road sign. Remember doing web pages, really not today since we have content management systems today, but in the sort of old days where we used divs to divide the pages. In the struct map, we can create divisions and grouping things together, grouping IDs, even the standard methods is using IDs to create the connections between different parts, which means you can create a rather elaborate struct map if you need to, or you can create a simple one. For the CSIP, the struct map is rather simple. When we talk about patient data and the eHealth 1 specification, this is used in a more elaborate way to actually create the patient and its data. Moving on to the next slide. So that was really the crash course. Just so you know that we are using the standard and it gives us some certain parts. That means that when you look into the CSIP, the requirements are grouped to the sections you saw on the previous slide. So one of the things when you use the standard METS is that you are asked to create a METS profile. So a profile of how you are using the standard. As I said, you only had one mandatory element in the whole standard. How do you know how to use it? That's when you create the METS profile. So there you describe your way of using the standard. What we are doing is actually creating the requirement tables from the METS profile because they are mirrors of each other. So we do have the master being the METS profile, which derives the requirements. So that's one way of connecting them. Moving on to the next slide. So, as I said, we have the CSIP being the master and being the basics. To that, we extend them. We extend CSIP to become the eArk SIP and the eArk DIP. And as you see on the slide, we add some extra attributes, which is possible to do some parts that are needed to really show this is a submission information package. The AIP is more a description on how you handle the package in an electronic archive. So when I'm handing over to Hannah Marie and Stephen, we will in most cases talk about the SIP coming in. So with that, from my last slide in the next page, I'm going to hand it over to Hannah Marie to take over and give the background to why we even have a CITS eHealth 1.
Thank you, Karen. Can you hear me?
Yes, we can.
Nice. So my name is Hannah Marie Hindle. I work at the Norwegian Health Archives, and I'm going to give you a quick brief of our legislation, systems, our standards, and some lessons learned. The Health Register Act provides a legal basis for the establishment of a health archive register, and with the health code regulations, the Health Archives Register was established in the Norwegian Health Archive. The register will consist of all material submitted to the Norwegian Archive. All hospitals, both public and private, are obliged to hand over the patient archive material to the Norwegian Health Archive 10 years after the death of the patient. The register will contain information on all deceased patients who have received health care from Norwegian hospitals. And we are an organization which is a department within the National Archives, but we are financed by the Ministry of Health and Care Services in Norway. Next slide, please. So the Health Archives Register, it gives us a unique possibility. Historical patient information is gathered in one place, giving researchers a unique opportunity to access information regardless of treatment location. And they may follow a patient's life and can access large amount of information, search for diagnosis, treatment, patient group, geographical similarities, etc. It is an eternal and new life for the patient records. And we also digitize patient records at our facility. This year we are going to digitize about 36 million pages. And we have our own standards, the eArchiving, which is a standard for both EPJ and DPJ, as I will show soon. Our system, we had a project in the beginning of a couple of years ago. When we started, we built a digital preservation system, which was built to preserve both digitized and electronically created patient archives. We keep track of the patient records with the Health Archives Registry Index, which is also known as HARI. And it consists of all the metadata in the patient journals, which we can extract. It's populated by a submission index, and we have a separate standard for the submission index that's known as AVL-XML, and that populates both the metadata in the register and also in the zip. So we make a copy in the register that's going to keep track of the patient journals, but we also keep like a snippet of the AVL-XML in the patient journal zip. As I said, we also digitize paper records, and we have tried to make the standard for the digitized material as close to the electronically created material as possible. This is to get some synergies between the two the different materials. There are some differences, but we try to make it look as similar as possible when it's packed into a zip. We have also created a submission validation tool. This is done to do a structural control and analysis of the AHR extract before making the EPJ zip. Next slide, please. So this is the overall system diagram. We have a virtualized on-site environment, which is automated deployment from Ansible Tower. We have Linux servers and also a tape robot as a bit storage. We have different environments. We have one production environment and one QA, and we try to mirror the environments to make it as similar as possible, so we can do all our tests in the QA. We have an expected throughput on about 350,000 patient journals every year, and about 450 gigabytes per day. So now, just keep it on the same slide, please. So the blue boxes are the core preservation system. We have Archamatica and pre-ingest and the bit storage. The green boxes are the register, which is populated by the AVL-XML and consists of all the metadata. And then we also have some external processes and external registers. As Karen says, she talked about the WISE reference model, and our system is built on the WISE reference model. We have the hospitals as producers, and the consumers is the next of kin and researchers. So we both have to find patients to hand out to next of kin and also to researchers. So we have in HARI, the register, we also have possibility to find one-on-one person and also do broad search on diagnosis and hospitals, etc. Next slide, please. So this is a snapshot of our workflow as we get an EHR extract. We have most of the systems are automatic, but the start is manual. So when you get to the control and analyze, we get into automatic systems. Next slide, please. And this part of the workflow is all automatic. We do a verification of the submission documentation, and we also do integrity checks, virus checks, and we analyze both the metadata and the material. And when we do, when we have the report, we do a manual evaluation of the results and make a check if everything is as it should be. Next slide, please. So to do all this possible, we have our own standards. We have the ePJ-ARK and something similar DPJ-ARK for the digitized. Our legislation defines the use cases for our archives, and the standards define the metadata, both the patient personal and the clinical, that should be included in the archival packages. The standards present a taxonomy for archiving patient medical records, case, subcase, documents, and files. Though the standards used are not based on international medical standards or archiving metadata standards. We have, though, the ICD standards, and we do have in our archival package, we do have METS files on premise, etc. But in the ePJ-ARK, it's focused on the EHR systems and what's possible to get extracted from the patient journal. Next slide, please. Yeah, so I was originally having a slide between those two with the ePJ package, but we're gonna add it into the final presentation afterwards. Though, for the moment, we have a pilot project for hospital submissions. One in Norway, we have like 4 huge health regions. So one of the health regions and one of the 2 main suppliers of EHR systems is cooperating with us and the Directorate for eHealth to make a pilot submission for the health archives. We have in this project, we are testing both transfer and packaging and analyzing and all the processes connected to an EHR extract. We are also looking at the standards to make further development of both the standards at the National Health Archives and also the national standards for ePJs. We have at the moment received our very first test, and it's looking good, we can say that. Next slide, please. So what have we learned so far? We have seen that the quality of submitted data is an issue, but good validation tools may help. Data packaging and validation tools can be pushed to suppliers. So if we can get the suppliers to add the validation tools into the EHR systems or the EHR extract systems, it may be helpful. Supplier partnership is important. We have two big suppliers in Norway. The one of them want to be a part of the defining the workflow. So we have this project, which it started, and it's both extracting EHR and also the transferring, because it's high security. We can't really just transfer the patient journals over the internet. We need a safe line. So we have also a project to do the transferring. eArchiving and the associated standards for the XML needs to be understood by the vendor of the AHR systems to be absolutely sure that we get the metadata we need to get high quality in our register, to get the information that is needed to do the research to be able to fulfill our legislation. We need the vendors to understand our standards. And we have this EHR validation tool. It's important to avoid going into a loop. We don't want to be in a position that we have to reject material over and over. So we have seen a lot of issues in the digitized material, and we learn from it when we go into project with the electronic material. And we see we also need to define the limitation of the EHR extract, because we have a huge backlog. We have thousands and thousands of patient journals that's waiting to be submitted. So we need to find like a best practice to find the best limit for a submission, if it's a maximum gigabyte number of patient, etc. So that's a quick brief to the Norwegian Health Archives. Now I guess Stephen is ready to take over.
Yes, thank you, Marie. So my name's Stephen Mackey. Can everybody hear me okay?
Yeah.
Excellent, thank you. So welcome, bienvenue from Finistère in France. My name's Stephen Mackey. I am privileged to be the main writer of the eHealth 1 content information specification. And I was involved as a project manager in the Norwegian Health Archives project, where we were involved in implementing the digital preservation system, which Hannah-Marie showed there in her presentation. And we've extended that work out into the work with the archiving building block in development of the specific software tool in association with that connected with the eHealth 1 work. Next slide, please. So first of all, I want to talk about the eHealth 1 specification. And we've seen a lot of technical detail around the base specifications, the CSIP, the AIP, and the DIP, and also some detail about the background in terms of the existing project at the Norwegian Health Archives. But I want to put this in a little more context and talk about the principles and the scope and the use case that we're addressing within the domain, which is about patient medical record archiving. Please forgive me. So why did this come about? So here is the statement of the CEF telecom call, which was the invitation to bid for creating the specification. And it says that specifications for eHealth will be developed by the activity. One specification based upon the Norwegian eHealth Archives transfer format of patient journals. So specifically, the building block records that there was a live project which had already been fulfilled for transfer of patient medical records from producers, i.e. hospitals, to a created central health archive. and that it was useful and helpful for us to build on that work and take the best parts of that to form the basis of a specification, which of course will be grounded within the existing common specifications. So in words, to standardise the work that had been done in Norway, provide a basis for similar projects throughout Europe. Next slide. So before we start, the first thing I found when I started to work on this is that there's some difficulty in terms of the terminology in this area. And so I want to set out some terms, and these are just terms as I've defined and the way that they are used within the specification and within the guidelines. Strict definitions or agreement on what terms mean don't exist. This is one of the things that I found out early on. And I can't amend that situation, but what I can do is to define what meanings of the terms are within the documents we're producing, to say, well, in this context, that is what we mean. And it's much more helpful if you are trying to write a specification that you have some semantics as a base for it to actually be very clear about what you're talking about. So, for example, within the domain, all agreement on the difference between an electronic medical record system and an electronic health record system. So I chose to use what are probably, some of the more popular or dominant views, which is there is a discrimination between these two systems, and that an electronic medical record system is predominantly a clinical system, and it deals with the management of patient medical records, and will tend to be situated within a institution or a group of smaller institutions that form a larger institution for management of that clinical process. And this is probably we're working with a specification is that we're dealing with, as Hannah-Marie described, we're dealing primarily with the submission of records from hospitals to a central health archive, and this happens at the completion of the record. And so just for completion, what I have defined as an electronic health record system, conversely, it tends to be a centralised system with wide access, and it has a broader remit medical in that it concerns the total health of individuals. And through observation, I've seen that we have systems, centralised electronic health record systems running through the European Union. Namely, we've seen systems in Estonia, we've seen systems in Finland. And quite often they're providing summary data, they're providing quite wide access as a service to the public, and it gives the public a view or transparency into their own healthcare, which spans above individual institutions. So those are my definitions, and say purely mine for the purpose of this exercise. The patient record, again, we have different terms used, and we've seen them today. The term journal is used quite a lot. For my definition, I talk about patient medical as being the collection or compilation of recorded information about a patient in connection with healthcare. And if looking at, for example, electronic medical record systems, these can consist of quite a number of different electronic file types. So the core of it still, these patient medical record systems are documents which consist of natural free-flowing natural language, and quite often are attested, so by a medical practitioner. But alongside that, you will get structured metadata and quite a lot of additional files, which can be images, they can be scans, they can even be genomic data. So there's a quite wide variety of different data can associate the core documents in a patient medical record today. And I then define a complete patient medical record as being the complete collection of those records concerning an individual. So a complete patient medical record would consist of many medical records. So patient medical records tend to be compiled as a linear activity concerned with a particular diagnosis or treatment. And they will be situated around a particular institution. And a patient medical record would be collated from different treatment episodes, and it would be collated from multiple institutions. in the Norwegian example, we were dealing with institutions or healthcare providers within that jurisdiction. And that's the case, the use case we see predominantly. But that's not to say that at some point in the future that a complete patient across borders, and certainly with the European Union as the drive across digital connectivity, then it's an aim that patient medical records and patient summary data should be more mobile. Next slide, please. So just to add to that, the local patient health archive, the production of patient medical records and then the storage of those patient medical records at individual institutions. We call that a local patient health archive. It is an archive because the hospitals, in some cases, where, for example, in Norway, the hospitals are required by law to. One of the reasons that the Central Health Archive was created was to actually take those records from the hospitals and to centralise themselves, who have managed to actually free up a lot of space from the paper-based records particularly. But a local health archive will exist in most hospitals, consisting of historical records for patients who may have been deceased, but they will retain records for legal reasons. And then the Central Archive we talked about, which is then this organisation which tends to be created through legislation, through government policy, and through government funding to actually create a centralised archive of these patient medical records, becoming complete patient medical records derived from the local archives for people who have received primary or secondary healthcare in the jurisdiction. And again, the scope can extend or be purely for secondary healthcare, and it can widen out into primary, it can widen out into more sort of therapeutic areas, and it can widen out into the private sector. So there is a lot of ability to actually define different scopes for this kind of archive. Thank you. Next slide. So use cases. The use cases that we used as the basis of the specification were based on the use cases which were described in the legislation within Norway. And that's not to say that use cases exist or that those use cases would be the basis of the system within a particular jurisdiction. As most of these systems will have to be funded centrally, and of course the government or the legislation will determine as to what use cases the Health Archive is being created for. But the two that actually were defined in legislation seem to make a lot of sense and could well form the base of other use cases around the European Union. So first of all, the first use case was about transparency. And the Norwegian legislation actually determines that patients next of kin should be able to access the health records for their relative. And this is a key around transparency. So obviously, if somebody has died, for an next of kin to actually seek out their medical records and get access to those and even sort of professional opinions about it. So that's part driven by open information regulation in that jurisdiction. And again, we've seen similar things. That use case is often met by centralised eArchiving systems, which obviously run while patients are alive, not just as to provide information to a next of kin, but to individuals themselves. And the second, and potentially the biggest benefit to society of the Central Health Archives is the one of research. And Hannah-Marie described about the kind of scope of information within the packages being generated within Norway. And throughout the world, there is a vast amount of historical data concerning patient treatment in hospitals. And quite a lot of this actually exists for a long time. And as Hannah-Marie described, the Health Archive in Norway have gone through a massive process of digitization of physical records, such that they can actually use this as a basis for creating cohorts of data for researchers. And as part of that, they're trying as much as they can to extract information from just documents and to create as much metadata as they can to allow that to be searched and selected and become the basis for code data for researchers. But if we consider the amount, multiply the amount of information that's in Norway for around the world, there is really a vast amount of information available to which could be made accessible to researchers. And so there's enormous benefit to society if it is created and made available. So those are the two uses for the Norwegian health archives. And already as part of the process we've been going through for writing and offering out the specification and guidelines for review, we've had, for example, that there are other use cases. And one particularly that's come up has been from some of the managers of these centralised EHR systems. And this is quite a different use case, which is that if you do create a centralised system, by its nature, the fact it's an online system, it tends to be structured rather than unstructured. So in other words, it's a big database which is accessible by individuals to see their own information. And the problem with databases is that they just grow over time. And of course, if you defined endpoint, it will just continue to accumulate more and more information over time as more people are born and more people create medical information. So the next challenge after creation of these systems, which are very projects, is that there has to be some process of management of the content and the archiving of content once the use of the system by the patient is no longer required. In other words, again, once an individual has deceased, then their records need to be archived. The use case for the centralised EHR is about managing storage space, so it's about cost. But also then it's about, so can we take that information and can we then again reuse that and use it as a pool of information for research? So there's an interesting extension to that thought process that we've been through, and also looking at the characteristic differences on these structured centralized information systems, and also the way that they tend to get their submissions. So a lot of the EHR systems that we've seen are getting submissions through which are quite defined specifications, but for which tend to be tend to be simplified summary information, what is often defined to be required within the EHR. So there'll be some more work, hopefully, to talk to any other organisations that have created centralised EHRs and see how that fits in within the overall project. Thank you very much. Next slide. So I'll just talk about the scope of the specification, and the scope really for creation of a central health archive. So we create this centralised patient medical record archive, and what is it that you actually want it to do? Well, as Hannah-Marie described, first there is probably a very large backlog of patient medical records. And it's likely that in creation of any centralised archive, we will want to operate the digitised versions of physical records, as has been done in Norway, as well as the newly created electronic records. And in the case of Norway, we've got decades of physical records going back, and electronic records start to come into force more around the sort of 80s and 90s. And of course, then the standards and the completeness and sophistication of those electronic also increases over time. So we're dealing with very characteristically different data sets coming from different systems and different sources over time. metadata, as has been described by Karen and by Hannah Marie, one of the key parts of a health archive, as in any archive, is the creation of rich metadata by which we can actually locate, search the contents of the archive to find what we're looking for. And because the basis of patient medical records is still at the core of it documents which are in free-flowing natural language text, then the metadata becomes very important. It can either be extracted from the source systems. Sometimes, in case of the digitization process, it has to be entered by operators as part of the digitization process and is taken from the data on the physical records or physical journals. And you can also start to look at using quite advanced techniques for extraction of metadata from documents. So, for example, with the Norwegian project, there is a plan to do optical character recognition on digitized documents. And once you've done the OCR, the character recognition, of course, you can use natural language processing techniques to start to try to extract, do pattern matching and extract metadata from the content itself. So there's a lot of work and interesting and development that can be done in that area. The aim of the archive should be to be complete. We talked about complete patient medical records, so extracting the records concerning individuals from multiple institutions. And it should try to take as a large snapshot of the situation within the jurisdiction as it can. And of course, security. I'm not going into detail about security, but this is a very, very important factor in the creation of any health archive. It's been dealt with within Norway very much in a technical and a physical sense. So Hannah Marie mentioned about the transmission won't be over open networks, over closed networks. And the actual facility itself, the Norwegian Health Archive, is in its own bespoke building with its own bespoke data centers. And even data centers have been split into two to provide a completely air-gapped red zone, as it's called, which actually contains the patient data itself. And then, of course, the dissemination of that data when requests are made and data is extracted in the archive, the dissemination generally involves a redaction and depersonalization, certainly from a research sense. So high levels of security which have to be considered or a core part of a creation of a health archive. Thank you. Next slide. So I want to give some idea of considerations that I had and some principle of the specification building on the work which was done in Norway and considering the use cases we're trying to address. And the first one is about patient centricity. Probably worth explaining a bit on this. I mean, Karen talked in detail about the e-archiving standards and the basis for the e-archiving standards being in standards such as METS, which is itself based on XML. And she explained that this is being done because these standards are very stable and very well defined. And this is a very important factor when you're considering building an archive. One of the characteristics of METS and XML, and I think as Karen showed, was that it is very hierarchical in nature. It considers an organization which starts at a point at the top and then actually goes down via these divs into more detail, much like the branches of a tree. So we work within that that structure, and for the health archive, the patient is taken as the top of the taxonomy or the top of that that organization. So the archive itself and the packages, the submission packages, are built with a principle that they will be patient-centric. And that ideally suits the then use case of the transparency and finding all the individual records for a particular patient. And of course, if we're then doing across the archive, which can be on many other different facets, then the information will tend to be extracted by patient. So you'll have the records associated with a particular disease, and that's associated with these particular patients. In Norway, when we were looking at the submission and aggregation of patient medical records, and remember that we're talking here about submissions from different institutions to form a complete medical record, it is impractical and necessary to actually aggregate those records to form a complete physical patient record at the archive itself. Those complete patient medical records will exist virtually and can be aggregated by search methods. Trying to aggregate them physically is very problematic, of course, because the submissions will happen at different times. You can imagine that within an institution that the patient has received their final treatment, then the submission of their record as a finalised complete patient medical record could happen fairly quickly. But within other institutions, they have got to wait until either they can actually see, in Norway, there is a death registry, and they can actually check with that and see if there are any patients that they have records for that are on the registry, and they could submit them. In some cases, it requires the institution to actually wait a number of years, and if there has been no confirmation, they actually submit the records anyway. So that's a period of time that it is not possible that somebody could still be alive, so they will submit the records. But the submission of records for individual patients can occur over quite a long time. The patient centricity actually determines that the highest level descriptive metadata associated with the package, aside from the descriptions of the package itself, is concerned with patient personal information. So it's the individual data, information about the patient, their name, their date of birth, their gender, their known addresses, etc., etc. So a little bit about aggregation structure. The submissions and the archive has to be organized in a particular way. And we base the specification around the very good work which had been done in Norway around the case subcase document taxonomy. I'll talk about that in more detail. And this, as far as we're aware, actually matches practice across most countries in terms of the way that patient medical records are organized within electronic medical record systems. And that is that we group different documents. Now, a document, if you remember, is a collection of files. It will always consist generally of a free-flowing text narrative in a file, and it's attested. And it's grouped different characteristics. So it will bring these things together, and it could be related to a period of time or a particular treatment. But it is a serial record of events which are concerned with a certain character. The specification allows for subcases, and this is for a situation where you have an institution which may have maybe a large institution which has a number of smaller institutions or departments as part of it with separate EMR systems. And you may, for example, have a treatment regime within oncology which is formed up into a separate record, a separate subcase, but is actually part of the larger case for that patient's hospital. Allows for bringing together documents within a subcase in the same case or multiple subcases. The document itself, which is a set of files with common metadata, and that could well be attested or signed. And then within the document, you have individual details. And of course, this is becoming more and more complex over time. So we have documents themselves, which could be PDFs, for example, but also they'll have images, which are scans coming out of radiology. We could have audio, we could have video, we could even have sequences. And some of these files will actually have standards associated. So an obvious one is DICOM, so a standard for archiving, or at least part of the DICOM standard actually specifies standards for archiving radiology scans, and associated metadata. And the specification takes account of the fact that it can incorporate containers such as DICOM in it, but there should be checks on the integrity between the meta, of course, which is encapsulated in the DICOM container, and between that and the metadata which is held at the package level. We do also allow for bit streams, in a separate sense, rather than just using a standard like DICOM, you could choose to actually have separate bit streams, say video and audio, within a file within a document. So there are many levels that can and don't have to be used. It's not mandatory within the aggregation structure. So lastly, a word on metadata. I think, as Hannah Marie mentioned, when one of the issues, from the e-archiving perspective of the Norwegian use case, is that use wasn't made of international archiving standards, and use isn't being made of international domain standards. And first of all, of course, the CSIP, the Common Specification, mandates the use of the archiving standards such as METS and PREMIS. So that important becomes part of the specification. But secondly, it seemed useful to actually recommend the use of national standards, domain standards, for the patient personal information, which is I've described is the core of the specification, but also for the clinical metadata, which will be the heart of the information which is actually use the data, particularly for research purposes, to be able to do these queries for cohorts of data across the complete archive. And a strong recommendation is the use of the FIRE resource from HL7, which provides resources for patient personal, also provides a large number of resources for different clinical aspects, such as conditions, allergen tolerance procedures, etc. So very good resources which define metadata standards and actually define them in different formats. So XML will be used in this case, but they're also defined in terms of RDF, etc. And the FIRE resources do also then reference, of course, other standards such as ICD and SNOMED. So clinical codes for condition and medical terminology within SNOMED. So this is recommended but not mandatory, as Karen described, as the way the specifications are written. And of course, the standards used for metadata are extensible. So those don't have to be used, others can be used, local standards. Also, they can be added to if it's considered that other resources are needed to describe other facets of the data. Thank you. Next slide. This is just a graphical description of the aggregation or the case structure that I described, and really just to underpin that the submissions to a central health archive, if they are dealing with legacy data, which is to be hoped it will be, and going right back to physical and therefore digitized patient records, that there will be a great range of different levels of complexity from the old to the new. So it also concerns the capability of the source electronic medical record systems to be able to extract data and submit it. So for example, electronic submission, some of the earliest and simplest EMR systems may only have the capability of extracting a medical record as a single document. Typically, it will be exported as a PDF, and so that's going to be, a proxy for the older case of the paper medical records. So it's basically giving free-flowing narrative within a document, a PDF. We submit it as a file within a single document, within a single case, within a single submission, and that's very simple. But as the EMR system is more sophisticated, then we start to see different cases start to be be created. So patients will have created or had created different cases for different therapeutic sessions. They may have within that multiple files, multiple documents, multiple files, even multiple bit streams within them. So a more complex situation where the submission will consist of multiple cases per patient medical record. And then even the situation as it becomes more sophisticated for larger institutions where we have these so there may be one or more cases for an individual patient, and that patient may have sub-cases, which also then consist of different documents and files and bit streams within that. Thank you. So that's really an overview of the specification, the eHealth 1 specification, and really to give some background as to the principles, the scope of the specification, and the way that it's structured. There is a lot of technical detail within the specification itself, which I would encourage you to look at. There is also now a guideline out for review, which gives some background as to the user specification and the context of it, which again, I would encourage people to read. And we are very welcoming, open to feedback as to how you see this, how it fits within your own organizations and jurisdictions, and any question you may have. So the next stage that we are just entering is now to look at creation of a software tool. And I think, as Jamie described earlier on in the webinar, as part of the eArchiving project and the building block, then we have different streams, one of which is the one for creation specifications, and one of which is the production of these software tools, which can be used to create systems, can be used to validate packages, and even put together within a reference architecture for creation of an archive. And the phase of the project we're entering is one that allows us to produce a soft support specification. And what we're going to do is, the problem we're trying to tackle is as described by Hannah Marie, which was that some of the challenges and the lessons learned in the creation of the archive are actually getting the patient medical records from the producers, from the hospitals. And as she described it, is that in many cases, to achieve that you've got to require that the EMR system vendors actually use software to provide conformant exports. In their case, it's the ePJ-ARK, which is the electronic patient journal archive package. And those are, in order to form those packages up, you'd need an automated way for the EMR system to actually gather data and to collate it and package it. And this is problematic. And of course, the eHealth 1 specification, we have a specification for a submission package. It's been put together in a certain way with a certain specification for the associated metadata. And we need to extract information from the source electronic medical record systems. In Norway, they have two predominant suppliers, but of course, across the European Union, there'll be many, many suppliers of these systems. And adaptation of every system to make an extract is probably not feasible. Hence, what we're intending to do is to develop an approach where a lower level of bespoke work at the system vendor or hospital level is required to actually create a process that will create the eARK compliant submission packages creation tool, and that can universally produce compliant submissions from data which is exported from source EMR systems. So the kind of vision is that using available DBA, or database administrator skills, that data is able to be exported through standard queries from the system. It's then able to be picked up by the software tool, which will then create the metadata files It'll create the package structure. These are things. So it will form a valid package, which can then be validated by the tools already available for validation of the core specification packages. And we could also, in future, as has been done in Norway, produce a high-level eHealth validation tool to actually check those exports. So in addition to that, in addition to the production of the software tool that we intend to document, so really then how that would work, what would a submitting institution need to do to be able to use the tool to create a compliant package. Thank you. Next slide. So requirements. We need the system, the semi-central health archive, which is being created, will need submission of client eHealth SIPs. So the intention is that we're providing a tool which is deployable at the submitting institution. Again, Hannah-Marie actually described this pushing of software tools to the hospitals is very possible and welcomed. So we're looking at something that can be configured and pushed from a central archive anywhere out to its own institutions for creation of these compliant SIPs. The SIPs, as described in the specification, can actually be for individual, but more likely will be for multiple patients per submission. You talk a little about this in terms of the Norwegian context. The EPJs that Hannah-Marie described can be very large packages and consist of thousands of patient records and then, of course, many thousands of constituent documents in those. And the ePJ-ARK is a aggregation of records from many patients, which is put together in a single package and submitted. This is likely the way that submissions will work. A submission periodically, which will consist of all of the new records they have over that period. The standard allows for creation of submission packages, which consist of records of multiple patients. In the Norwegian example, and what is envisaged to be recommended here, is that those are then split when they reach the Central Health Archive, and the archival packages are created for individuals. So we retain that patient centricity. And the reason for that is, of course, that if for the first use case, which is actually getting data for a single individual, then it's much more convenient if the output from this archive is the information for a single individual, and you're not receiving a package which has many, many thousands of records in it, which you've then got to extract the information you're looking for with its associated dangers from a security perspective. So the workflow in Norway is that we have these aggregated submissions, and the preservation system and the archive system, which Hannah-Marie showed, one of its initial tasks is to split these up into individual SIPs that are then passed into the preservation system, and it then produces the individual AIPs. And that can be accommodated within the archiving specifications, as that we have a compliant aggregated SIP. It can be split into compliant non-aggregated SIPs, and we can produce compliant AIPs, individual AIPs. There may be local requirements. It's recognised, of course, that what we're trying to do is not to be overly prescriptive in terms of the mandatory requirements for what should be included. And the specification has to be flexible enough to include any local requirements which extend arbitrary or adopt some of the optional requirements within the specification. So, for example, the metadata standards, the use of standards, fire standards is recommended, but it's not mandated, and there may well be local country standards, national, which want to be used. The use of submission agreements. Submission agreements are a core part of archival practice in terms of included document submissions, and we do have submission agreements included in packages in the Norwegian workflow. But this I actually changed this quite recently on review, because it was something that was advised. It's not made mandatory, for example, in submissions in and Estonia. So that has been made optional, but recommended is that there should be an agreement between the submitting organisation, the producer, and the archive, and a copy of that. It is helpful to have a copy of that within each pack. And lastly, simplicity. The key thing on this software development activity is that we want to make the workload and the onus on the hospital to be as low as possible. One of the key things in this domain, of course, is being conscious that the primary concern for everybody is about patient healthcare. It's about providing healthcare. It's about improving patient healthcare and patient outcomes. And the creation of a health archive and placing additional requirements on local IT staff is not are aligned with their core objectives. So we want to try this as simple as possible, such that they can do it as a benefit to them, as they can see downstream in terms of the research outcomes. But we're not actually increasing their administrative overhead if we can help it. Also, that we're using standard platforms and we're using common IT skills. Again, there shouldn't be. We're trying to get past the problem of there having to be bespoke development work on applications, and we're trying to be on the point where you require any particular IT skills which wouldn't be present in the hospital already. Thank you. Next slide. So, timeline. We published the draft content information type specification, the SITS, in September last year for review. The review for that closed around January, if I remember rightly. Comments, but again, it'd be very useful if anybody wants to look at that, and I will certainly accept any comments still formally. As we go through the second phase of the project for the software development, our own practical experience of applying this is going to be invaluable. And of course, and I will be reviewing and revising the specification still before its final publication. So we intend to start the actual development of the software in May this year. Next slide, please. Oh, and by the way, what's in the interim there, we've also put out a guideline document for review, which I believe is available. Helpful, certainly, if you're not an archivist and you're not. You may find it, if you're not really interested in reading the specification tables about the METs, then the guideline is a good place to start and covers a lot of what I've sort of been through today as the sort of background context for the specification. In June this year, we should get into software testing, and we are looking for collaborative for this. So we really will need to have institutions who are willing to participate in providing us with test data and be able to test this whole principle of trying to do the extracts from EMR systems simply and without the use of particular specialized skills. The final specification we published around August this year, and I say I'm going through a review process currently, so and we'll continue that do the software development, because I may find that there's more detail I need to add, and certainly there may be more detail and contextual information to add to the guide. And then following that, we should have the software tool finalized and the documentation finalized and published in October this year. Next slide. So that's it. That's quite a long section from myself, and I hope that was back to Tom, I think, who will take any questions.
Wonderful. Thanks a lot, Stephen. And thank you to all our speakers. I think that was a very interesting session indeed. So we have some time here now for questions if you have. I'll give participants a moment to think if they want to ask anything. Jamie's been very kindly sharing lots of informative links in the chat. I would make a special rappel for the satisfaction survey, so that obviously we can help, you can help us even constantly improve the sessions that we run and how these webinars are done, and basically have your say. So please do. It takes only 30 seconds. It's very quick, very light. So please do that. And you can see here all the links to the guidelines, specifications, and also how you can contact us. So, indeed, I don't see any questions coming in. But I think we can. Okay, well, I mean, I'll give it still one more moment if people are coming up with, basically thinking of their questions or their ideas. But it would be for me to say a huge thank you to all our speakers who've taken their time to be here today and provide us with these. DICOM has been mentioned today. Is this a file format that you deem suitable for long-term preservation? We would like to.
I can say something about the Norwegian view on it.
Please, go ahead.
Yeah, at the Norwegian Health Archives, we think it's suitable for long-term preservation because the DICOM consists of both JPEGs or TIFFs with the XMLs that explain the context of the pictures. So we accept DICOM as a part of the long-term digital preservation formats.
Thank you, Hannah.
I could say a little bit of word about preservation formats, Tom. And it's a good question because the eArk classification is considering the format of the submission package and the way that the content is organised and described, and it actually specifies the use of premise as a way of documenting preservation actions. Because the decisions about the preservation and which file formats and the preservation engine you use and the different tools you use is a separate matter, which is all parts of that planning process for the actual archive and the preservation system itself. So our scope goes so far, but that's a very interesting one, and probably the best place to, as with a lot of these deliberations about long-term archiving file formats, is looking at best practice. So I think Anna Marie's input is very useful here, and something we should look at in terms of, for example, the pro file format registry, and the scope of that in terms of how well it supports currently the file formats or containers that are prevalent within patient medical record submissions. That's another area that potentially needs to be explored.
Wonderful, thank you, Stephen. Okay.
And I can also add in, Karin, here, that is also depending on the national legislations. So it's actually a combination of what's a suitable format and what does your legislation say.
Okay, thank you very much, Karen and everyone. So we have the question, what about an appraisal of medical records in Norway? Is that a stage that should be built into the workflow of digital archiving, or are the records supposed to be preserved in their entirety? It's a Norwegian specific question, so maybe over there welcoming other speakers to come in if they have.
Yeah, this might be it's a bit difficult to answer because we are a lot of standards are changing at the moment, but it was supposedly to be preserved in their entirety. So, but now we have started new systems. We have started like one patient, one journal. We have cooperation in making the patient journals across the hospitals. So we have like a new situation, how to maintain and extract the whole information. We don't have the entire picture yet, but it is the main goal to preserve the whole patient record as is, both with documents and metadata from the past systems. I don't know if that's enough.
Sorry, Hannah, I lost you there for a moment, but I don't know if it was just me and my connection, which has been a little bit shaky, if that was for other people. Would you maybe just repeat the last the last 30 seconds, just in case everyone missed what you said? It may have just been me. Just
I'm not quite sure how much you missed, but originally it was meant, we were meant to preserve everything, both the documents and information from the past systems. Though we have some issues now because things are changing, systems are changing, and we are experiencing some challenges with one patient, one journal across hospitals and across who creates the journals. So we are supposed to preserve the entire patient journal, but there are challenges there.
Wonderful, thank you. I heard that clearly. I hope everyone else did. Okay, excellent. Are there any more questions from participants? Obviously, if you do have more questions or more detailed questions, you can see here the contact credentials for all our speakers as well. So obviously, you can contact them, and if you're interested in reusing the eArchiving building block, then you can reach out to us via the CEF building blocks email address, which you can see here, or you can launch by the service desk on CEF Digital, and we have onboarding teams. Here we go. According to the presented scope by Stephen, there are examples of organizations where they on a large scale use the archive function as a function for storing outdated information for the current general system.
Yeah, it's a good question. So I think it probably relates to what I described as an additional use case to the ones that we used as a base Norway for the specification. And this is the one of the space management of local or centralised health or medical record systems. So we I haven't actually seen yet examples of people having done this, organisations done this, but we have had it described to us as a challenge. So it's something that we're quite keen to get involved in, because superficially it's an IT problem. And of course, if it's dealt with as purely an IT, then you're purely into space management techniques or archiving in an IT sense. And you're not archiving following standards, which we creation of an archive for an archiving sense. So it's important to bring these two worlds together, and it will be very interesting to get involved in this kind of activity to make sure that when information is archived, that it's actually archived according to standards, and that it is then therefore useful in the future, usable as a resource, particularly for research.
Wonderful, thank you, Stephen. We then have a question asking any idea how to preserve data from specialized workplaces, such as transplantation centers, may a SIARD format as the timestamps. Yeah, which of our speakers would like to comment on this?
Either myself or Karen. I don't know. Karen, do you want to answer, or shall I?
I think you know more about those specialized workplaces than I do, so go ahead, Stephen.
Well, I'll start. So this is an interesting area. So it's really the sort of comparison between two sort of fundamentally different ways of storing data, which is the unstructured way, or predominantly unstructured way, which is the way that health records or health journals have been stored in the past. And I think Hannah Marie indicating herself some of the complexity in this, because of course as time goes on, a lot of data is not stored in this way. It's stored in the structured way in relational databases, and it starts to present different challenges in terms of archiving. Now, this is something that is being tackled within the eArch project. We have a eHealth 2 specification. And eHealth 2 is actually looking at one particular use case, which is that of cancer registries. But cancer registries, like a lot of centralised registries, are relational database systems which aggregate information from different providers and then also provide input to, higher level centralised aggregation systems. And they're there for the purpose of actually researchers be able to view. They tend to be structured in nature, so based around relational systems. And so the eHealth 2 specification is considering the archiving of snapshots of database information in registries through the use of the CEARD specification. If anybody doesn't know, I mean, CEARD is a specification for archiving relational database systems through the use of the XML. So it's taking it and making them system independent, such that the data can be reused in the future. But because they're coming from live database systems, these tend to be snapshots. They're doing an archive, if you like, or a snapshot over time, repeatedly, rather than just once. And it could well be that at the moment we've got two separate streams and specifications being developed, that these things will start to converge. And I already mentioned that particularly the use case for centralised EHR systems, which are relational database systems. And I think, as Hannah Marie has mentioned, about the increasing complexity and sophistication of local EHR systems, plus this use case for the registries, or has said here, specialised workplaces like transplantation centres, then we may have to look at, consider over time the sort of convergence of these two different cases.
Wonderful, thank you. Wonderful. Okay, we still have 9 minutes of our allotted time. Obviously, if no one complains about having a bit extra time for lunch, but we still have some time for any remaining questions. And of course, as said, we will publish the recording of this session, so you'll have access to all these insights. Okay, I don't see anything coming through. So again, I'll just thank Karen, Hannah, and Stephen for joining us today. And thank you, Jamie, for your intervention on the building block. Sorry if you can hear a siren in the background. For their insights and their views and their presentations. And thank you all for joining us here today for this session. I think it was great, and I hope it's useful going forward. And we look forward to staying in touch with you in the future. Wonderful. Thanks, everyone. Bye-bye.